He has a diplomate in healthcare management from Harvard University, USA, and earned his Master of Hospital Administration at the University of the Philippines. He is a Doctor of Philosophy in Human Resources Management, earned within the University of Santo Tomas. Presently, Father Manlangit is professor at the University of Santo Tomas, Faculty of Medicine and Surgery, and Faculty of Graduate Studies. So I'd like now to welcome our three esteemed speakers. And our case is focused on end-of-life care. This is our first case. So Mrs. Cruz's Mr. Cruz is an 80-year-old retired professor who has been battling end-stage chronic obstructive pulmonary disease, or COPD, for the past several years. His condition has gradually deteriorated, leading to his reliance on mechanical ventilation in the intensive care unit. And over time, his medical team has diligently managed his care. Recently, there have been signs of improvement in his respiratory function. However, it is believed that Mr. Cruz's underlying health conditions have stabilized to the point where he no longer requires mechanical ventilation to sustain his breathing. But Mr. Cruz has two children. So he has two adult children, Emilia and Jaime, who are actively involved in their father's care and decision-making. They are deeply attached to their father and have consistently advocated for aggressive medical interventions to prolong his life. Despite the medical team's recommendation to discontinue the mechanical ventilation, Emilia and Jaime are unwavering in their insistence to continue this life-sustaining treatment. They are concerned that any attempt to remove the ventilator might lead to a rapid decline in their father's health. So, as this is the case, there are three important questions that we would like to address. First is, how should healthcare professionals navigate the tension between respecting patient autonomy and honoring family wishes in the end-of-life care decisions? Secondly, we are also concerned with what legal considerations come into play when making decisions about withholding or withdrawing life-sustaining. And thirdly, we would like to explore how healthcare providers and families can address the spiritual and emotional needs of the patient and family members during this challenging time. So just to summarize, in our case, we are interested in the ethical, legal, and spiritual care dimensions of care for Mr. Cruz. So at this point, I would like to invite our speakers. I would like to begin with Dr. Valencia to comment on the ethical issues, particularly in terms of autonomy and family wishes. Dr. Valencia.
Good afternoon. Oh, good evening. Good evening, Dr. Calderon. Good evening, everybody. Thank you very much for the invitation. In this case, when we're talking about the patient autonomy, there are two situations, there are two determining factors to determine patient autonomy. One is that he's competent and aware of what is happening, no? Now, in the case of Mr. Cruz, we can see that his patient autonomy, we cannot use his patient because he's not conscious anymore. In cases like this, we follow the three principles of it would have been better if he left a note or he left an affidavit stating what he wants to do after if anything ever happens to him. But in this case, if none of that is available, then we go to the principle wherein we follow the one who's a surrogate will have to follow what he thinks, how he thinks the patient, Mr. Cruz, will act in his stead. So the surrogate will be the one to decide what he thinks is best, depending on how he thinks that Mr. Cruz will want, no? Seeing that he has two, the daughter and the son. So the they will have to decide based on what they think their father would like. Now, the third way to decide on this would be the best principle, which is for them to decide what they think is best in this case. Um, it's a very difficult talaga in cases like this, no? Kasi nga, the patient is not able to talk for himself. That's why we have to decide based on the surrogate decision maker. Now, knowing that it is also very important to consider the legal aspect. That's why we have to ask Dr. Apostol what she thinks would be better or what is best in terms looking at it from the side of the law naman. But the medical professionals, kasi the healthcare professionals always have to consider those principles when thinking about taking care of these patients. Now, it's difficult also na the patients kasi want to give of course the relatives, no, the daughter and the son wants to give the best for their father. So they didn't know that even if knowing that even if they continue to give that support, it is not going to be able to treat the father anymore, no? So maybe we should also consider the futility of treatment, and seeing that the futility of treatment is primarily Catholic. No, it's primarily based from a Catholic perspective. I think Father Jerry would be able to talk more about that, no? But in this case, we should know that infertility kasi we have to consider whether it's an ordinary and an extraordinary means of treatment already. So the ventilator, if it's not going to be helpful for this patient, would already be considered extraordinary. So there. Thank you, Dr. Calderon.
Yeah,
Yeah.
thank you so much, Dr. Valencia. So we're just warming up, no? Thank you very much for uh, presenting us your views about the various ethical issues ranging from whether a surrogate decision needs to be made, who's going to make it, and what's the basis for for um, for for deciding on this. So I think this is an important case to showcase, the different aspects of surrogate decision making in end of life. And like you mentioned, there are legal considerations that come into play, particularly with withholding and withdrawing life-sustaining treatment. So I now invite Dr. Apostol to comment on this case. Hi, Kay.
Hi. Thank you, Dr. Calderon, Dr. Nikki. Well, firstly, as to legal considerations, actually, when I was reading this vignette, I wasn't quite sure whether we are dealing with a unconscious patient or a conscious patient. It's just that the decision making has been exercised throughout the confinement by the adult children. So let us just hypothetically, we're talking about a conscious patient. The first legal consideration, of course, is whether or not we're getting the consent from the right persons, because legally speaking, the decision of the patient himself or herself will always trump the decision of the next of kin, whether the spouse, whether the children, the parents of the patient, if the patient um, is competent to give consent. And generally, that is presumed in law if the patient is an adult and is of sound mind. So let us suppose that this patient na lang is incompetent to give consent, so that we can talk about the other legal considerations. Suppose this patient is incompetent to give consent, or suppose the patient is competent to give consent, but he is in agreement with his children that he doesn't want to be let off the ventilator. personally, and this is my humble submission from the legal perspective, really you can't either decision whether to keep the ventilator on or hooked to the patient, or withdraw the ventilator from the patient, the mechanical ventilator support from the patient, either would be legally justifiable courses of action. Um, Although as a lawyer, I would always try to advocate the course of action that would be less legally risky. So in this respect, I think it's legally safer in terms of which one invites the lesser likelihood of a lawsuit. It would be to keep prolonging the life. I'm not saying it's, of course, ethical. This is purely a legal perspective, a perspective that would advocate against lawsuits, in other words. So why would I say that's a legally safer route? Because whatever happens to the patient, it's really not the patient you would have to deal with as a physician. It's whoever is left, the heirs. And if the heirs wanted to have prolonged the mechanical ventilator support and you went against those wishes, then obviously that would be inviting a lawsuit. So I think it's legally safer to just prolong the treatment, although it might not be ethical. Kasi nga, when it comes to ethics, you have to, as discussed earlier by Dr. Nikki, you have to consider matters like futility, principles of beneficence, and such. And of course, we are also bound by these ethical principles as physicians, not just the legal parameters. But it is perfectly justifiable, legally speaking, to prolong kasi they want. So if we prolong, then we can fall back on this, I presume, documented consent that they want to keep the mechanical ventilator on. Now, if we were to withdraw the ventilatory support against the wishes of the family members, then honestly speaking, although that is legally risky, evidently because if anything happens, it's easy to see how the doctor might be blamed there because they didn't want to remove the ventilatory support, and there you go, you remove the ventilatory support. But given the scenario kasi, it appears that it is actually within standard of care to remove the ventilatory support. And really, our obligation as physicians is to observe standard of care. In our decision making, that is our primary concern, which is to promote the health of our patients. And our foremost responsibility, according to our code of ethics, would be to do no harm to our patients. So really, if it is within standard of care, it is what a reasonably competent physician of average merit would do under the situation, under the circumstances, then that is actually the proper course of action. So say anything goes wrong, there would be a perfectly valid defense for the physician to defend against, say, a lawsuit for medical malpractice. But yun na nga, it's legally risky because it goes against the wishes of the family of the patient. On that note, I would like to say, though, that we have to remember that the necessity for getting consent for instituting, or the necessity for getting consent to discontinue an intervention, is not on par with the necessity to get consent for instituting an intervention. The latter one, I do believe, is pretty much necessary in any scenario except for emergency cases. But yung getting consent for discontinuing an intervention, we do that all the time in some way or form without consent. In our regular practice, we discontinue meds, we shift antibiotics from IV to oral, we discontinue IV fluid resuscitation, And do we get consent from the parents or from the patients, I'm sorry, or the relatives? No, we don't, because it's not legally necessary. And in this scenario kasi, it would seem like the discontinuation of the mechanical ventilator support per the best clinical judgment of the physician is actually beneficial to the patient. It will be in the best interest of the patient. It is in keeping with standard of care. So we're not talking about a scenario like passive euthanasia, wherein if we remove the ventilatory support, then the reasonable possible consequence would be death of the patient. No. In that case, I think we do have to exercise a heightened degree of care in securing consent. But that's not the case here. Actually, yung gusto ng relatives seems to be against the best interests of the patient. So yeah, that's what we have to remember when I say that it's legally justifiable, easily legally justifiable to just withhold the ventilatory support in this instance. And that's because I only say that because in this instance, withholding ventilatory support is clearly within the best interests of the patient. So that's all I have to impart for this particular case. Thank you.
Yeah, thank you for your insights, Dr. Apostol. So just to recap, now we have a case of an elderly person who, from a medical point of view, the medical team thinks that the patient no longer requires ventilation, but the family members are insisting. So far, Dr. Valencia and Dr. Apostol have walked us through the legal and ethical, the potential and legal.
Good evening, everyone. Good evening to all participants, panel of discussions, MC, our MC, Dr. Carbon, suffering, etc. But it comes to emotional, psychological, is one of the most difficult things to resolve. But anyway, it is Emilia and Hyman were afraid that the discontinuance of the ventilatory support will certainly bring or deteriorate or is going to harm the patient. But despite the fact that the doctors have assured them that the ventilation is not anymore necessary and that the father can be sustained with his breathing without it. Okay. In this particular case, the doctor should have taken this as a golden opportunity to teach and to educate them about the intricacies of medicine. Medicine is not a cure-all and be-all. Let's accept that. It is not a cure-all and be-all of everything. It has its own limitations. And by the time we have reached that limitation, it's time to say no. Okay. The removal or the discontinuance of life-saving device does not mean you reject life. Neither does it mean that you are going to kill the person. No. The implication of the removal of life-sustaining device, which you know are already unnecessary, only tells us two things. One, if the removal of life-sustaining device leads to the death of a patient, it's not because he died because of the withdrawal, but because the body cannot anymore sustain, or the system or the organs cannot anymore sustain the whole body. It only means that life-sustaining device is now useless. That no matter how you try to support it, it comes a time that it will not be able to sustain life. Suppose the removal of the life-sustaining device is still makes the patient alive, the life-sustaining device is still useless. Because if the removal can still make the patient survive. And what's the use of the life-sustaining device? So it's useless. So the removal of which does not tell us the implication that you want to kill the patient, or the patient is not going to survive, because it's not anymore needed. The doctors had already told the siblings it's not anymore necessary. And whenever you come across with issues about death and dying or terminal illness, one of the things that doctors should be able to do, the attending medical doctor or at least the hospital, must have a policy about family conference or medical junta, for that matter, laying all the cards on the table, that if something like this happens, then the doctor already knows, the family knows, and they will be well oriented as to what's going to happen, and therefore there will not be a lot of class about emotional attachment or everything. No, medical junta is very important in the care of patient, especially when it is about terminal illness. We know also that it is a matter of fact that good medical practice suggests that only interventions that are useful can be administered to patients. Useless intervention is bad medicine. It is even very costly. Remember Julian Loeb's law in medicine. All of you doctors should know this, and probably you must have come across with this law, Julian Loeb's law in medicine. If what you do works, continue doing it. If what you do doesn't work, stop doing it. If you do not know what you are doing, do not do anything at all. That's Loeb's law in medicine. Patient autonomy must always be respected. But remember, it is not absolute. It is not absolute. Autonomy is about patient self-determination, meant for his best interest, not on the opinions of others, even loved ones. It looks like that the patient is better off without ventilation, and that deterioration of patient is not fast enough not to have ventilation reconnected in case something wrong happens. Withdrawing of life-sustaining device in this case is morally tenable, as it is not going to harm the patient, contrary to the thoughts of the children. In the family conference, so it is where spirituality should come in. Or in the medical junta, a chaplain should be invited to be able to meet the higher needs of the patient, as well as of the children who are present. There must be a moment spent in this very important activity, aside from the medical needs. This is where the spiritual needs can be addressed or inserted into the equation. Spirituality is positively welcome in healthcare, as many studies have already spirituality in healthcare. Because when you talk about health of patient, you are talking about holistic health of patient. And we know very well that the patient consists in different dimensions: the physical, the mental, the psychological, the social, the moral, and the spiritual. That is why, in one way or another, physicians should also be spiritual, because it is in this case that a spiritual doctor, a patient, or rather a doctor who is spiritual and who knows how to pray for the patient will have a higher likelihood for the patient to heal. That is well studied in Harvard, because doing so generates a lot of serotonin when a doctor is able to communicate not only in terms of the medical language, but of spiritual language. It addresses the needs not only of the body, but also of the soul. It would be good if the chaplain is also conversant in bioethics in this case, so that he can be at the same time at the same page with the doctors, although that is not necessary. Spirituality is important in healthcare. It completes the whole treatment from the physical to the spiritual. And that is where you'll be able to see, again, according to the research, that when spirituality is inserted into patient care, when the physician knows how to pray for the patient, when the physician knows how to share his faith, or whatever is the faith of the patient, 32% more likely that the patient is going to improve. That has been well researched. Thank you.